Welcome to our discussion on the pharmacotherapy of men and women's health. Now, obviously, in the course of one lecture, we're not even going to scratch the surface of this topic, but I've picked a few topics that I think will be most pertinent for you as nurse practitioners in primary care. We'll be discussing medications used to treat BPH, as well as those used to treat erectile dysfunction. We'll hit on some of the basic considerations for oral contraceptives and some of the other prescription contraceptive agents, as well as discuss medications used to treat urinary incontinence in both men and women. Our first discussion topic will be the pharmacotherapy for benign prostatic hyperplasia, or BPH. Now, with this disease state, the goal is to improve symptoms, limit progression, and prevent complications associated with untreated disease. And per guidelines, watchful waiting, drug management, and surgical intervention are all appropriate depending on the severity of the disease and the disease symptoms. So with that, let's get started by discussing some of the agents used to treat this disease state. The most common class of medications used to treat and manage symptoms of BPH are the alpha-adrenergic antagonists, or alpha blockers. Now, BPH has a dynamic component to it, and that's increased smooth muscle tone. The alpha-1 and 2 receptors are located within the prostate, and the prostatic stroma is more highly associated with alpha-1 receptors. Stimulation of these receptors is associated with constriction of the prostate smooth muscle and therefore urinary obstruction. So you can see if we can antagonize or block these receptors, it prevents that constriction and obstruction. So this class of medications works by that mechanism of action and often provides quick onset of symptom relief within days. Two commonly used alpha-1 selective antagonists are the long-acting agents, terazosin and doxazosin. They're approved for hypertension and BPH, so you may remember a little bit about them when we talked about antihypertensives earlier in the course. They're considered long-acting because their half-life is approximately 12 hours, which then usually allows for once daily dosing with these agents. And oftentimes we do dose at bedtime to help avoid some of the orthostasis symptoms that may be associated with these medications. For these agents, there's data to support their use, and that data have demonstrated improved peak urinary flow rate, mean flow rate, and post-void residual urine volumes. So positive effects on all three of those parameters. You typically start with low doses of these agents and titrate to relief of symptoms. Starting with a high dose or a maximum dose increases the patient's risk for hypotension or orthostasis. So typically starting with the very lowest dose and titrating up to symptomatic control is the best approach when prescribing these agents. The alpha-adrenergic antagonists can be further subclassified into the uroselective agents. And these agents are considered uroselective because they have the ability to relieve BPH symptoms with a decreased likelihood of systemic adverse drug reactions or hypotension. So really focusing their action locally versus systemically. And basically, one of the principles of them being uroselective is the fact that the alpha-1 receptor has been further subtyped into alpha-1A, 1B, and 1D. And the two agents that we're going to discuss are alfuzosin and tamsulosin. Tamsulosin is long-acting, like the long-acting terazosin and doxazosin that we previously mentioned. It does have selective antagonism at the alpha-1A subreceptor. It acts by decreasing intraurethral pressure and does not have a systemic blood pressure reduction typically associated with it. Now, that being said, at the higher doses of 0.8 milligrams per day in patients who are at risk for hypotension, you still may see some systemic effect, but the risk is decreased compared to the other agents. When dosing this medication, it should start at 0.4 milligrams daily. Usually no titration is required, and you may not see that much added benefit by increasing the dose to 0.8 milligrams. So cost-benefit wise, it's always smart to start low on this medication as well and titrate to effect. It does have some side effects associated with it, and one which is significant that patients may complain to you about is abnormal ejaculation. And the mechanism behind this is it's likely due to relaxation of the bladder neck, and that can cause retrograde ejaculation. And this may be concerning for the patient, but it typically doesn't lead to adverse consequences. Therefore, if you can counsel the patient through it and it's still controlling their BPH symptoms, that's not a reason to discontinue this medication. However, that being said, it is often a reason that patients will want to discontinue this medication. Unlike tamsulosin, alfuzosin is not selective for a specific alpha receptor subtype. However, it is still considered uroselective because it selects prostate over vascular tissue and exerts most of its mechanism of action at the prostate level. There's even less systemic hypotension with this agent, and because it isn't specific for the alpha-1A receptor subtype, it doesn't result in significant ejaculatory dysfunction. Now, looking at the profile for this medication, you might ask, well, why don't we just give this medication to everybody? Well, that being said, oftentimes treating BPH is a cost-benefit approach. These newer uroselective agents tend to be more costly, and the alpha blockers, the long-acting alpha blockers, oftentimes have just as good of an effect in the patient that can tolerate those agents. So rather than going to the new Cadillac version for everybody, it's important to consider what patients will tolerate just the standard therapy. And if they'll tolerate those and that will control their symptoms, those should still be our first-line consideration. A second class of medications used to treat BPH are the 5-alpha reductase inhibitors, and the two that we'll mention are finasteride and dutasteride. These agents reduce the hypertrophy of the prostate gland itself, and we'll talk a little bit about how that happens. The 5-alpha reductase enzyme is responsible for converting testosterone to dihydrotestosterone, or DHT, and that occurs in the stromal and basal cells of the prostate. DHT itself is an important prostate growth regulator. So inhibiting 5-alpha reductase inhibits prostatic enlargement. So we're targeting an enzyme with these agents, not necessarily a receptor, as we talked about with the alpha-adrenergic antagonists. Just to point out a few things specific to each of these two medications, finasteride is a specific inhibitor of the type 2 5-alpha reductase enzyme. This type of the enzyme, the type 2, is predominant in the stromal cells and basal epithelium of the prostate, and it basically acts to regulate hyperplastic growth. In studies, finasteride has been shown to reduce prostate size by about 20 to 30% in the studied patients. And this is important to point out for this class that the key predictor for positive treatment outcome is baseline prostate volume. So a prostate volume baseline of greater than 40 mils is needed to see a benefit or a good outcome. So if you have a patient who doesn't have a prostate that's enlarged to 40 mils, this is probably not the class of medications that's going to offer them any additional benefit. Unlike the alpha blockers, where we said that onset of symptom relief was quite quick, such as days, there's an average of 6 months to detect significant urinary symptom reduction with the 5-alpha reductase inhibitors. So that being said, you'll often see these used in conjunction with the alpha blockers for the immediate relief as well as the potential benefit of that prostate size reduction if the patient has a baseline prostate size of greater than 40 mils. Now, dutasteride is slightly different in its mechanism of action, but in that it inhibits both the type 1 and type 2 5-alpha reductase enzymes, but it has similar considerations as the above that we mentioned per finasteride. So it also requires that the patient has an enlarged prostate volume baseline of 40 to 50 mils in order to see benefit from the use of these agents. I wanted to just help tie the pharmacotherapy all together with treating BPH and managing the symptoms. So I put together the next few slides to discuss the drugs of choice. If you have a patient with mild BPH, watchful waiting is the recommended standard. Many of these patients lack symptoms and some may never experience disease progression. So watchful waiting if you have mild asymptomatic BPH. If your patient's experiencing moderate to severe BPH, this is where your role for the alpha adrenergic antagonists come in. If you're concerned with blood pressure issues with the non-selective agents, you can use the uroselective agents. However, as I mentioned previously, from a cost-benefit standpoint, if your patient will tolerate terazosin or prazosin, those are your agents of choice first line. And you would consider the 5-alpha reductase inhibitors as an add-on therapy if the patient has a prostate size of greater than 40 mils. And finally, we're not talking about this as the focus of our discussion, but it's obvious to mention that surgical intervention is often needed for severe BPH or BPH with secondary complications. We're now going to shift gears and talk about medications used to treat erectile dysfunction. And again, I'm going to focus on the medications that are more likely to be prescribed by primary care providers versus urology specialists. The most commonly prescribed agents for erectile dysfunction, and definitely the most heavily advertised agents in direct-to-consumer advertising, are the phosphodiesterase inhibitors. And these agents are listed for you here: sildenafil, vardenafil, and tadalafil. These agents act by inhibiting phosphodiesterase type 5. And this then inhibits the degradation of cyclic GMP, and increased GMP levels result in relaxation of the cavernosal smooth muscle. So that relaxation of the cavernosal smooth muscle is basically the primary mechanism of action of these agents. One point is that it still requires arousal to facilitate response. So that's important for your patients to know when you counsel them on these medications. While these medications all act with a similar common mechanism of action, they do have some kinetic differences. You can see that the onset is about the same for most of the agents, anywhere between 10 minutes to around an hour for most of these agents. The food effect is something that's important for your patients to know. So for sildenafil and vardenafil, there are issues with a high-fat meal delaying the time to peak effect of the medication. So if a patient has just eaten a high-fat meal and takes their medication, it may take a little bit longer for them to see the onset or peak effect. You can see the agents do differ in their half-life, with sildenafil being the agent with the shortest half-life and tadalafil being the agent with the longest half-life. Now, depending on what your patient is looking for, you may use this half-life to their advantage or not. Some patients do want the opportunity to not have to time their drug to the expected time of intercourse. So for those patients, tadalafil might be a better option because they have a greater window of opportunity, if you will, where sildenafil and vardenafil tend to be a little more planned. But you'll find that most patients really don't have one preference versus the other. It's more of a discussion for you to bring up with them, and also look at cost. Certain patients may have one of these on their prescriptive formulary but not the other. So that's another consideration to take when you're choosing an agent with your patient. Anytime you're discussing phosphodiesterase inhibitors, it's important to also correlate them with avoiding nitrate use. And I'm sure many of you who have emergency room experience or experience treating patients with acute MIs have gotten accustomed to asking your male patients, have you taken a phosphodiesterase inhibitor or have you taken any medication for erectile dysfunction within the past 24 to 48 hours. And essentially that's a direct contraindication for using nitrates in those patients. Basically, the reason for this is there's a rapid additive hypotensive effect from vasodilation. Since the phosphodiesterase inhibitors are vasodilators, adding another potent vasodilator on can obviously cause a rapid decrease in blood pressure, which you don't want to do for these patients. The exact safe window is not well established, but based on the half-lives of the agents, you may say 24 hours for all of the agents except tadalafil, which is probably 48 hours based on its longer half-life. In similar fashion, these medications should be prescribed with precaution for patients on concurrent nonspecific alpha blockers for BPH, such as doxazosin, terazosin, and prazosin, the three that we've talked about earlier. And for a similar manner to the nitrates, that's due to systemic vasodilation and hypotension. Tamsulosin or alfuzosin are uroselective, and they have less hypotension associated with them, so they may be a safer choice for a patient in whom you're going to prescribe a phosphodiesterase inhibitor. Another thing to counsel your patient on is that they should avoid large amounts of alcohol if they're planning to use their phosphodiesterase inhibitor, as acute alcohol consumption may result in additive dizziness with these agents. Another thing that it's important to do is screen your patient's medication profile for any drugs that may be affected by cytochrome P450-3A4 inhibition, as there's potential drug-drug interactions with those medications. Lower doses are required in patients with renal and hepatic dysfunction, and many patient populations haven't been studied, so you need to consider that if you're looking at a patient who may have risk factors listed here. So recent MI patients, recent stroke patients, heart failure patients that are class 2 and higher, uncontrolled arrhythmias, and hypotensive patients. There's really not good data for using phosphodiesterase inhibitors in these patient populations. Therefore, at present, it's probably best to avoid prescribing them for these patients. This medication class typically has a low incidence of adverse drug reactions, other than the ones that we've previously mentioned that are oftentimes based on drug-drug interactions. Priapism is uncommon, but obviously warrants urgent medical attention, so your patient should be counseled on what to do in that case. The most common adverse drug reactions include headache, flushing, dyspepsia, and that's due to the fact that these agents relax the lower esophageal sphincter and can result in some reflux, and vision changes, and it's thought to be due to the inhibition of the cyclic GMP phosphodiesterase 6. As I alluded to earlier, there are other agents for erectile dysfunction, and I'll refer you to your readings to discuss those. Those agents are typically second line and typically recommended and prescribed under the advice of a urology expert. A couple that I've listed for you here include apomorphine or intracavernosal injection of vasoactive drugs. So again, likely not to see many of these in a primary care type setting, but it is important to know for you to be able to use these as second line options or a referral to a urologist should some of the first line therapies not be working or an option for your patient. The next topic that we'll be discussing in this Men and Women's Health lecture is oral contraceptives. We'll also touch on some of the other prescription medication contraceptives that are seen in primary care as well. It would take an exorbitant amount of time to go through each oral contraceptive preparation and discuss the minute differences between them. So what I'm going to hit on are some of the major differences and concepts with the oral contraceptive agents. Most of them on the market now are combined oral contraceptives, or a combination of an estrogen component plus a progestin component. And I've listed examples of the estrogen components and progestin components for you here. When taken perfectly, less than 1 in 100 women will have a pregnancy on a combined oral contraceptive. It's important to recognize, though, that many people do not take these agents perfectly, and missed doses can result in an increased risk of pregnancy. Some of the literature out there cites anywhere between 5 and 7 in 100 women will have a pregnancy with what they call quote-unquote typical use. So typical missed doses, typical misuse, but that again is variable depending on the source that you look at. But with perfect use, it's less than 1 of 100 women will have a pregnancy. You can see on the flip side for the progestin-only tablets, they're slightly less effective than the combination oral contraceptives. For the progestin-only tablets, it's estimated by data that 2 of 100 women will have pregnancy with perfect use. And again, that goes up with typical use, more to the realms of anywhere between 8 and 10 of 100 women will have pregnancy with typical use. The mechanism of action is based on both the estrogen and progestin component for the combined oral contraceptives or the progestin component alone for the progestin-only pills. In the estrogen side of things, estrogen acts to suppress LH and FSH and prevents ovulation. It alters also the endometrial lining and hinders the implantation of the egg. So a couple different mechanisms of action based on the estrogen component itself. Progestin also blocks LH and causes cervical mucus thickening, which acts as an entry barrier. It also reduces fallopian tube motility, which decreases sperm transport. And as with estrogen, it alters the endometrial lining and hinders the implantation of the egg. So you can see that there's multiple modalities that these two components are working to prevent pregnancy. As you can see, oral contraceptives are not without adverse effects, and some of the adverse effects are typically associated with the estrogen component, while others are typically associated with the progestin component. You can see in this table that nausea and vomiting and irritability and bloating edema and cyclic headaches tend to be associated with the estrogen component. One of the more serious side effects associated with the estrogen component that is obviously at an increased risk in women over 40 who also smoke are clots, and we'll talk about the aches mnemonic in one of the future slides. But it's very important to encourage women of any age who are going on oral contraceptives to quit smoking. It's just not worth the risk. Probably the biggest adverse effect that patients complain of with the progestin, or that's related to the progestin component, is increased bleeding or increased flow or spotting. So if you notice that your patient on a progestin-only pill is complaining of this, adding estrogen in to their preparation will probably help control that. And also listed for you here some decreased mood, decreased libido, diarrhea, fatigue, and this can actually induce lactation in some patients as well. So all considerations when you're looking at the preparation for your patient and examining the adverse effect that you're seeing. I'm sure most of you have already learned and studied the aches mnemonic for blood clots for patients on oral contraceptives, but I think it warrants review one more time. And you can see that remembering this mnemonic really helps you to focus on counseling points for your patient as they relate to the clots from an estrogen component of their oral contraceptive. So A stands for abdominal pain. If your patient's having severe abdominal pain, they need to be seen immediately. If they have chest pain, cough, or shortness of breath, obviously that could be the signs of a pulmonary embolism or a myocardial infarction due to a clot. Severe headache, weakness, and numbness are all associated with strokes or a clot to the brain. And similarly, eye and vision problems or severe leg calf pain can be associated with clots in the eyes or the brain or in the calf or a DVT. So if you can counsel your patients to use this mnemonic to remember symptoms that they need to seek medical attention for right away, that will be an important point for them to take with them when they use these medications. I'm going to spend a minute or two talking about some of the other contraceptives that are available for your patients who may not want to take oral contraceptives or who may not be able to comply with them to the degree that's necessary to get that less than 1 in 100 pregnancies. The first that we're going to discuss is depomedroxyprogesterone acetate. And Depo-Provera is one of the brand names of this agent, and it's given as an intramuscular injection once every 3 months. Using depomedroxyprogesterone acetate, approximately 3 in 100 women will have pregnancy. And that may seem at first glance higher than the 1 in 100 of oral contraceptives, but considering the risk with oral contraceptives may be higher with what we refer to as typical use, it actually may be better for the patients who are non-compliant with oral contraceptives. They might have more success with that 3 in 100 versus the 7 to 8 in 100 women having a pregnancy with typical use of the oral contraceptives. So kind of have to keep that in mind when we're comparing raw numbers. Its mechanism of action, since it is a progestin-based medication, is that as per the progestin description. And it's important to caveat that none of the methods that we've talked about today or will talk about today prevent sexually transmitted diseases, and that's always a very essential and important counseling point with your patients using these for contraceptives. Another available option for women who may not want to take an oral contraceptive or receive a shot is the Ortho-Evra patch. The patch is a combination estrogen-progestin product, so it works as per the combined oral contraceptive agents. It's just in a transdermal vehicle. And I've included a picture just to give you an idea of the relative size and kind of look of the patch. The patch is changed weekly times 3 weeks, so one patch once weekly for 3 weeks, and then no patch is applied on week 4, and that's when the woman would expect to get her menstrual period. It should be applied to the buttocks, stomach, upper outer arm, or torso, and the studies did take a look at heat, so patients who were working out and sweating. It also looked at cold, and it looked at patients getting wet with the patch on, and it showed no difference in absorption, so there's no expectation that efficacy would be altered under these situations. Now, it is a problem if the patch falls off, however, so that's different. That's a consideration where if the patch falls off, the woman should put a new patch on as soon as she notices that it's off and peeled away, and consider a backup mechanism of contraception, a barrier method. Another estrogen-progestin combination contraceptive that's delivered via a novel device is the NuvaRing. And as I mentioned, it's an estrogen-progestin combo, so it works the same way as the combined oral contraceptives. And I included a picture for you to see again the size and look of the NuvaRing. And this ring is inserted intravaginally once monthly. The patient leaves it in for 3 weeks and removes it for week 4, and she would expect to have her period at that time. So this is another option for patients who may not want to use any of the other options available, or who are concerned or are having problems with the patch falling off and don't want to receive an intramuscular injection every 3 months. The final topic that we're going to discuss in this lecture are medications used for treating urinary incontinence, and this could be in both men and women. Urinary incontinence can be more than just a social issue or a nuisance problem, if you will, but it can actually be associated with severe consequences. And if you think about it in the setting of skin breakdown, urinary tract infection risk, and increased falls risk for patients trying to get to the toilet, as well as increased risk of institutionalization, so it's not a small problem. Determining the underlying cause will help us guide therapy, and that's what we'll talk about in the next few slides. Just as you have the ACE mnemonic to help you remember clotting and estrogens, there's the diapers mnemonic for incontinence. And we'll go through that quickly here, but it stands for delirium as a source of incontinence, infection, so if someone's got a urinary tract infection, that can cause incontinence, atrophic vaginitis and urethritis due to decreased estrogen levels, oftentimes in postmenopausal or perimenopausal women, pharmaceuticals, so drugs can induce incontinence, psychological factors like anxiety, excess urine output, so polyuria causing frequency, so this may be a sign of, say, an uncontrolled diabetic patient. Restricted mobility, so your patient isn't able to make it to the bathroom and therefore have episodes of incontinence. And finally, the S stands for stool impaction or constipation, which essentially is due to an increase in bladder pressure from that impaction or constipation. Assessing the type of incontinence that your patient has will help direct the therapy that you choose. So we're going to briefly go through some of the basic differences between the types of incontinence. And again, this is not all-encompassing pathophysiology, so if you want to read more or need to learn more to understand this fully, please do. But this is just to help you differentiate when it comes to choosing a drug therapy. The first type of incontinence is stress incontinence, and this occurs during episodes of elevated intra-abdominal pressure. So typically that associated with urine loss when coughing, laughing, sneezing, or lifting heavy objects. It occurs most frequently in women and is often, it also can occur postpartum short-term in women as well. Urge incontinence is characterized by the loss of moderate to large amounts of urine with the inability to delay voiding if the bladder is perceived on being full. So if the patient feels like they have to urinate but they can't delay voiding until they get to the bathroom, they have that loss of urine volume, typically a larger volume than with stress incontinence, and that would be considered urge incontinence. It's often also associated with increased frequency. Overflow incontinence is related usually to outflow obstruction, and it's characterized by leaking small amounts of urine, a poor stream, dribbling, and feeling of incomplete emptying. So an example of this would be the type of incontinence often associated with BPH. Functional incontinence is basically the patient's functionality is fine, but they just can't make it to the toilet. So it might be due to an underlying dementia or someone who isn't able to walk well to reach the toilet, so they have episodes of incontinence. And then finally, there's an all-encompassing mixed incontinence, which would, as the name implies, be two or more underlying pathologies. For treating incontinence, there are multiple non-pharmacologic therapies, and I would encourage you to read up and learn those as well, simply because in many cases the non-pharmacologic therapies such as pelvic wall, muscle strengthening, etc. can help as much, if not more, than some of the pharmacologic therapies. But since the pharmacologic therapies are our course focus, we're going to discuss the alpha-adrenergic agonists, estrogens, tricyclic antidepressants, and other anticholinergic medications for incontinence. Again, to mention the importance of non-pharmacologic therapies such as pelvic wall muscle strengthening exercises in the case of treating stress incontinence, because they're often the best choice for this type of incontinence. But when we go for a medication to treat this, we're looking at the alpha-adrenergic agonists, estrogens, and TCAs. So we're going to talk about each of those in a little bit of detail, starting with the alpha-adrenergic agonists. So as the name implies, these are agonists at the alpha receptors in the bladder neck and internal sphincter. So that causes a contraction of the smooth muscle, an increased sphincter tone, and they're not really considered in most treatment algorithms due to lack of evidence. So these aren't well studied, but they are an option should you choose to use a medication for this type of incontinence. An example is pseudoephedrine, and it is sometimes used to manage mild stress incontinence. The issues with pseudoephedrine now, as you know, is federal regulations allow only purchase from behind the prescription counter, so it's not really, it's over the counter, but the patient has to sign and show proof of ID, etc. So it's not as easy for patients to get pseudoephedrine as it used to be. So again, they're not often used, but they are an option if you want to start with something that's over the counter. For postmenopausal women with urogenital atrophy, estrogens are the treatment of choice for stress incontinence. And there are topical and intravaginal preparations that typically work just as well as oral therapy. So that's a case that would have to weigh the risk and benefits of using an estrogen versus using alternate means to control the incontinence, again referring back to the non-pharmacologic therapy. Tricyclic antidepressants have also been used. The hypothesis is that the TCAs inhibit norepinephrine uptake, and then they may increase urethral tone due to enhanced alpha-adrenergic effects. And the one that you'll see used most widely and oftentimes used for bedwetting in children as well is imipramine. It's important to remember that, as with any of the TCAs, imipramine exhibits anticholinergic properties. So if you're using this for stress incontinence in an elderly patient, the anticholinergic risk may not be worth the benefit that you'll get from this agent. Now we'll discuss briefly the pharmacologic agents used for the treatment of urge incontinence. Anticholinergics are effective for controlling urge incontinence. However, there's a questionable decrease of acetylcholinesterase inhibitor efficacy if the patient is on an anticholinergic. So if you have an elderly patient who's being treated for dementia with an acetylcholinesterase inhibitor, it's probably advisable to stay away from an anticholinergic. The reason being is the acetylcholinesterase inhibitor is trying to increase the amount of acetylcholine, and the anticholinergic will decrease it. So you're kind of counteracting the drug that you're using to treat dementia if you use an anticholinergic for incontinence. So again, this plays back to the importance of assessing the underlying cause and concomitant medications that your patient may be on. Oxybutynin acts as an anticholinergic and smooth muscle relaxant, and it can be used scheduled, so the patient takes a long-acting preparation, or if they typically know that they're not going to be able to reach a bathroom for, say, 6 hours if they're going to see a play and out to dinner or something like that, they can take it before their event and just use it as needed rather than scheduled. Tolterodine is a competitive agonist of the muscarinic receptors. It is metabolized via CYP2D6 and 3A4, so you can expect some drug interactions based upon that. But again, acting in a similar method as the other anticholinergics, however, it's just acting as a muscarinic receptor agonist. And finally, the TCAs can be used, and they're really just they're being used for their anticholinergic side effect profile. As I alluded to earlier, overflow incontinence is most often related to BPH in men, and pharmacologic agents previously discussed for BPH would therefore then be the treatment of choice for overflow incontinence. So again, considering your alpha-adrenergic antagonists as well as your 5-alpha reductase inhibitors for your patients with prostate baseline volumes of greater than 40 mL. I'd like to thank you for your attention during the course of this lecture, and I realize that we covered sort of a broad range of topics in this short lecture, and we didn't necessarily go into tons of detail in specific scenarios. So I encourage you to please do your readings and post any additional or more detailed questions that you have regarding the content on the Ask the Pharmacist link for this module. Thank you.